Thank you for inviting me along to this webinar. As you've heard, my name is Chris Borge and I am a lecturer in nursing at Glasgow Caledonian University. This short talk will have a discussion around evidence-based practice, and in particular it will focus around real-world evidence. So the example that I'm going to use when I'm speaking to you, and you'll see that a bit later on, is around case studies. And I'd also like to look at the context of where they fit in within the range of evidence that we have available to support our practice. Please note that this topic has been condensed into a bite-sized overview. A number of the themes and topics within here are taught over sometimes a couple of hours, sometimes days, and indeed sometimes entire modules at various levels within university education. So it is a bite-sized introduction, but hopefully that will give you some food for thought to start reading around and looking beyond some of those topics independently. So, when you're going on holiday, does your browser look a little bit like this? Mine certainly does. Really busy. I've got every single page open, every single flight page open, every hotel page, every single review page, scrolling through the results. So if your answer to this is yes, then we're already really singing from the same hymn sheet from the outset, really. Because what I'm doing here is, before I book my holiday, spend my hard-earned cash on a nice holiday, I've looked at the numerical data. So I've looked at the price of the flights. What value can I get there? What's the best class of flight that I can get for that money that I'm going to spend? What's the quickest way to get there? So a lot of numerical data. I'm also going to look at some qualitative data. So in particular around things such as how clean was the hotel? What did people think of the hotel? What are some reviews of the flights, etc.? What things are around the hotel? Looking at that big picture before I make that individual decision. So I've researched around making the best decision for me to have the best holiday at the best price and have the best time available. So if that is you as well, and it's not just around holidays, it's around lots of things, buying cars, buying anything new, buying a new washing machine, then actually you're really on a good road towards being able to find research, appraise research, and also find the best available evidence to provide the best available care to your patients. The first thing that we've got to understand here then is evidence-based practice. We've looked at it in a sort of day-to-day experience of something within our life, but actually when we look at it in the context of healthcare and the care that we provide in the context of, say, wound care, we've got to be able to think about it from a more evidenced, and we've got to look at some literature to support what we're saying. So what does the literature say? So this is a quote that I quite like explaining evidence-based practice because I think it encompasses a lot of elements. The important things to me here are around this collection and interpretation of data, and we'll cover a wee bit of that later. The fact that we're talking about things that are patient-reported, clinically observed, and research-focused. These are all really important. But actually, at the core of all that, within this definition, we also talk about the quality of clinical judgment and producing those outcomes for our patients, because we all want the best possible outcomes for our patients. So let's break evidence-based practice down a little bit more. So evidence-based practice is an amalgamation of research evidence. So what I like here is, in this diagram, is that it talks about the best available research evidence. And we'll unpick that a little bit later on in this talk. And that it doesn't just say research evidence, it talks about the best available, and there's a good reason for that. There's obviously patient preference and values. So if we then take that into context, our patients would sort of be secondary to what we're doing, but we know that they have to be at the heart of everything that we do. Clinical experience and expertise, we know that there's not always evidence for things. Through the COVID pandemic, quite often we were actually just phoning around and there was sharing of information where clinical experience and expertise was what we were working on a day-to-day basis. However, for evidence-based practice, we need an amalgamation of these things. The part of this that I'm going to focus on is around research. Now, most people, it will be healthcare practitioners, whatever field of practice that is, or whatever discipline that is, they'll have some understanding of research. So really, as a reminder of what research is this process of an inquiry. It's systematic. What do we mean by it's systematic? It follows the research process. So I've not cited the research process within here, but just as a reminder of what the research process is, it's a systematic approach to investigating a problem. And asking a research question, reviewing literature, because that's really important that we review literature in the context of what we're asking. Then designing a study, and we'll talk about study design because we're going to talk about case studies, and I suppose that reflects within there that collection of data, and then how we analyse it and then present it. So we often talk about dissemination of data. So that's what research is. Now, I've given 3 quotes here. Some of you will be familiar with them from sort of pre-registration education, but I think it gives a nice balanced view of what research is, and there's something there for everyone to understand depending on what way you think. So we've talked about this research, and we're kind of maybe flipping backwards a little bit here, where we talked about the research process, but that disseminated piece of research that we've got will then be graded within a hierarchy and the levels of evidence. So this hierarchy sits within this pyramid, and it's a simplified version, and I often use this because it's quite easy to understand that it has 5 levels. At the top of this is level 1 evidence. That's randomized controlled trials and your systematic reviews. So they're the highest level of evidence. We talk about them being high level evidence because they've got the least bias, they're transferable, and they're generally generalizable to a large population, and we'll understand why that is in a minute. However, as we go down the levels of evidence, you'll see that things such as case series, case studies, expert opinion are much lower down. But what I'd like to emphasize is that by the end of this talk, that they're no less important than any of the other evidence. We still need it within the context of our practice and what we do as healthcare practitioners. The Scottish Intercollegiate Guideline Network actually produce a more detailed version of this, and I quite like it. It's not sat in a pyramid anymore. They just explain it, and they have a little key so that you can see within their best practice guidelines what level each bit of evidence is that they cite. However, ignore that for a second, but I like the way that actually it breaks it up a little bit more. It pushes up these non-analytical studies, case studies, reports, and gives them some credit up there at number 3, which I really like, because actually we're really seeing the value of them. So just as a reminder, we do have 2 main research approaches. You'll be probably familiar with these, and that's quantitative and qualitative. Quantitative, where we're looking much more at scientific data, often concerned with numbers, numerical data. It's often analysed through computer statistics packages. It's deductive in its nature as it moves from what is known in the literature, and it tests applicability in other situations. We minimise variation, so we try and keep all the variables the same, apart from maybe one, or minimise them. And we can generalize it in that it's probably applicable to a large population with similar characteristics to those that are within the study. Qualitative, on the other side, is much more subjective. We're looking much more at descriptive elements here. We are gaining an understanding of a phenomena, of something that's going on. We interpret what's going on. So we maybe analyse interviews, we possibly analyse transcripts of interviews or focus groups, just to give some example, case studies, etc. And we interpret that using themes, for example. These are just examples. There's lots of ways depending on methods used. However, we interpret these and we try to draw themes from that phenomenon. They do report a rich narrative. That's a real thing that I will demonstrate in a second. And it's really focused around the participants generally. And they're not always patients, bearing in mind that they can be clinicians, they can be a whole range of different people. And then bringing these together, don't forget, and it's out with the scope of this talk, we also have mixed methods where you use both approaches or a combination of approaches and combine them together to make good quality studies as well. So that's an overview of the two main approaches. We know about these approaches, and hopefully you're already thinking, in your context, so within wound care, can I always use level 1 evidence? Well, in short, the answer is no. So I'm going to give you an example from my practice. I recently conducted a study understanding student nurses' perceptions of caring for patients in clinical practice. Now, the word perceptions maybe gives it away here. Not every student will have experience of this. So I had to study perceptions. And for yourselves, that might even be relevant to yourselves. So how does this fit into the previous slides? Well, quite automatic, you probably are starting to think it is going to have to be qualitative data. Quantitative data probably here isn't going to give me very much. I can ask, do you have experience? Yes or no. Did you feel confident? And maybe put it on a scale. But actually, that's maybe as far as that goes for this study. What I want here is this rich narrative. So what I've provided here are some verbatim quotes from my study. I'm not going to read them all out individually, but if you do have a little read of them on your own, what you'll see is that there's some real food for thought there. And as a researcher, I kept my data collection around interviews that were semi-structured. I didn't have a rigid structure. It was quite free-flowing. I could ask a question and then take it wherever that participant was going with that information they were giving me. That gave that rich narrative of data, and actually I found things that I hadn't thought of, and that's really good in qualitative research. And this is about exploring real life. So going back to the topic of this webinar, about exploring real life here, so real life research and real life stories that can really fit into our research, or not fit into our research, but actually can give rich research findings. Let's think about this in relation to wound care. Within wound care, I'm no expert in wound care. I will hold my hands up. However, from having discussions, I'm very, very aware that actually it's very difficult to minimise variables among your patient groups. I'm pretty sure, especially the range of wounds that there are, and the context of where people are at the time when they have these wounds, the history, all these different things are variables that are really, really difficult for you to control. And so therefore, that makes randomized controlled trials very, very difficult. Sample size. Randomized controlled trials, so for quantitative data, you need massive sample sizes or very large sample sizes. For qualitative, the example of my study, my sample size is only 6 or 7, and that's completely fine for a study of that size. And you can actually have smaller depending. If anyone's looking into that, Brown and Clark have a textbook and about qualitative research, and actually has a nice table on sample sizes and illustrates that to you. The other thing is cost implications. To do randomized controlled trials, it's time consuming, it takes a lot of work, there's massive cost implications. And then on top of that, you've got an evolving market of products available. That scientific development within wound care is taking leaps and bounds. And so therefore, both of these things, by the time you get this randomized controlled trial going, it might be that the products that are available have improved no end and making that not possible. Something that you will note is that best practice statements are available and they will have randomized controlled trials, but they're not specific to any product. It's generally around leg ulcer healing, etc., for various other reasons that they'll have done randomized controls, as opposed to doing an actual product. So where do case studies fit into this? Now, if some of you read some of the textbooks, there is a little bit of controversy around case studies, and there are a number of other qualitative study designs. So, for example, within education, we use a thing called action research. And again, sample sizes are small, it's lived research, it's day-to-day research within the lived world, and it really feeds into and improves our practice as it can for you with case studies. So case studies is a used methodology, and case study methodology does exist and is documented within the texts. It usually focuses around individual patients, a person, so I'm saying person because not always patients, remember, groups of people or cohorts of people with specific characteristics. That data collection can be through a variety of methods. It can be through clinician observation. It can be through things such as, I suppose, focus groups, interviews with those individuals, or them getting to write their narrative, and I'll talk about that at the end. It does provide a rich narrative. You do get an abundance of data, and it does take a lot to decipher it and identify these themes. However, it's much easier to explore complex issues that you can't explore with what would probably be a superficial exploration using more quantitative methods. It can influence future studies. They're often very good as initial studies or being exploratory in their nature and guiding further studies that are more specific to certain things. I think, and if you read about them, patient narratives, as I've just mentioned, they can also be very useful within wound care. I have cited an article here, and it's around what is a case study. It's a very short article. It's a page and a half to 2 pages, and actually that's worth reading if you are interested in using case studies as part of research that you might do. Finally, not to forget quality improvement. Quality improvement is not research. However, bear in mind that case studies or the research that you do from these can then feed into quality improvement projects and actually improve practice that we have. Quality improvement is much easier to do on a small day-to-day basis. So bear in mind from your case studies that you collect, it might actually let you identify what change can we make here that will cause an improvement and take it through those cycles of improvement. So finally, here are some key references. There are a number of other references within there, but these are the key ones for the information rather than the diagrams, just to guide if you want to read any further. And thank you very much for listening.
Good evening, everyone. I hope you're all well and I've been enjoying our first speaker. I have. My name is Astrid Fremau and I'm part of the Medical Affairs Department at Flen. Now, in what follows, I'm going to guide you through the results of a large-scale clinical evaluation of our product Flaminol. These results build further on data that we obtained and published in 2018. Now, time flies. Being already 5 years later, we thought it's about time we provide you all with an update. So this clinical evaluation of Flaminol follows on from the Jones and Oates publication of 2018, which included 356 patients. Now in this updated evaluation, no more than 1,657 patients were included, who all applied Flaminol for the treatment of their wounds. Now, being applied with so many patients, we wanted to know about the performance of Flaminol, about its clinical effectiveness. To do this, we used the wound assessment framework TIME, which is the most commonly used wound assessment tool in Europe, which you will know. TIME as an acronym standing for Tissue, Infection, Moisture, and Edges, is a clinical decision support tool, which provides a structured approach to wound bed preparation. This publication is an example of real-world evidence that can be utilized to support evidence-based practice. It also includes some nice case studies, which Katharine will move on to in the next session. And yeah, real-world evidence that was very nicely discussed by Chris in the first presentation of this evening. Now let's have a look at the 2 key objectives of this clinical evaluation. So first of all, we wanted to emphasize the importance of accurate wound assessment using the framework TIME. And secondly, we aim to evaluate the continuous performance, the continuous clinical effectiveness of Flaminal in wound management. How did we do this? Well, we asked our UK district nurses to complete one evaluation form per patient to document the performance of Flaminal. This specific product evaluation was performed in the UK between February 2019 and November 2020. The questions on the form all related to the time framework, and following the collection of all evaluation forms, the data was analyzed, and the analysis included a statistical analysis using a standard binomial test. Now let's have a look into the results of this large-scale clinical evaluation. So as said, a total of 1,657 product evaluations were collected, which related to a very wide range of wound types. A couple of examples here on the slides. So these wound types included some of the most commonly treated wounds in the wound community, such as leg ulcers, pressure ulcers, and diabetic foot ulcers. About 2/3 of the patients use Flaminal Forte, which is, as you know, indicated for more highly exuding wounds, and that is thanks to its higher alginate concentration. Compared to Flaminal Hydro, here on the left, the blue one, which is indicated for low to moderately exuding wounds, and was used in 31% of the patients. Now, the other 3% of the patients used both, so both Flaminal Hydro as well as Flaminal Forte over the course of the wound treatment. Following the time framework, the first step is evaluating and managing the tissue. More specifically, the removal of fibrinous slough of necrotic tissue. And here we saw that no more than 81% of the district nurses reported an improved wound bed upon using Flaminal. That result was also statistically significant. Another aspect when managing tissue in wound care is evaluating healthy granulation tissue, or tissue that is bright red, moist, and granular in appearance. Over the course of the treatment, it was seen that 77.5% of the district nurses indicated an improvement in granulation tissue when using Flaminal. Also here, the result was statistically significant. From the T of time, we move on to the I, standing for infection. It was noted that upon using Flaminal, almost 73% of the clinicians reported an improvement in infection signs. Now, in this case, it's good to mention that when no infection signs were present at the start of the wound treatment with Flaminal, also the answer option, no change, indicated here on the slide in yellow, is an important outcome, demonstrating the ability of Flaminal to prevent the wound from getting infected. When we then questioned the moisture management by Flaminal, we saw that no more than 82.6% of the district nurses indicated that the moisture was well managed using Flaminal. Now, given that approximately 2/3 of the treated wounds in this evaluation had moderate to high exudate levels, well, yeah, this outcome for Flaminal was critical. And then last but not least, the wound edges and the surrounding skin. Almost 70% of the district nurses indicated that the condition of the wound edges and surrounding skin had improved with the application of Flaminal. Also, this result was statistically significant. And here, again, when the wound edges and surrounding skin were healthy at the start of the wound treatment, the answer option, no change, here in yellow, is a good result, as you aim for or you want to maintain such healthy wound edges over the course of the treatment. 3 points of discussion still before it's time to conclude this presentation. First, a structured wound assessment is required at the initial patient contact with a documented holistic framework, including photographs, including measurements. As mentioned, this product evaluation and the data obtained with it build further onto the Jones and Oates publication of 2018. The results strengthen the outcome of 2018 publication and highlight the ongoing performance of Flaminal in addressing every aspect of the time framework. Then, thirdly, the questions asked in the evaluation all reflect an important factor in managing the barriers to healing, and the results shown are significant to relate to real-world practice, as well as to the need for a suitable and cost-effective dressing regime. To conclude then, sandwiching dressings or using multiple dressings to tackle the different aspects of wound care can cause, as you all know, complications in practice and will result in increased costs. That is why a dressing that on its own can address the many barriers of wound healing will undoubtedly benefit the patient, the healthcare professional, as well as the NHS in terms of cost effectiveness, in terms of ease of use. This large-scale clinical evaluation is, as said, an example of real-world evidence. It shows that Flaminal's versatile characteristics allow it to be used throughout the wound healing continuum, as it promotes autolytic debridement. Flaminal offers antimicrobial protection. It keeps the wound moist while offering absorption of excess exudate. And last but not least, it protects the wound edges of the wound. One last thing which I would like to mention is that we as a company, we keep on monitoring the performance and the safety of Flaminal and our other wound and skincare products on a continuous basis. If you feel you would like to contribute, or if you have specific suggestions or questions for us relating to your use of Flaminal, then please reach out. Contact us, contact your local sales representative, and let us know what you would like to discuss with us. Because having such discussions with you, well, that is our guide moving forward. And with that, my time's up. I hope you've all enjoyed the session, and thank you for listening.
I'm Catharine Rolland, and I am a tissue viability nurse specialist in NHS Lothian, which you may know better as Edinburgh in Bonnie, Scotland. I've been a tissue viability nurse now for just over 5 years, and I cover community and acute, and I'm very passionate about pressure ulcers, but really I just love all wounds. Thank you so much to Flaminal for having me on today to host and also to talk about my case study. So I'm sure either you've read or you're just about to read the Wounds UK article. And what I'm doing today is I'm just going to explore in a little bit more detail one of the case studies that you will read about in that paper. And here it is there. So the case study, our gentleman is 59 years old. He's got COPD, psoriasis. He's quite a heavy smoker. But despite this, before becoming unwell, he was pretty well. He drove a school bus 5 days a week and had a good quality of life. He was brought into the acute hospital on the 5th of January with a pneumonia and renal failure. As well as that, he had this new erythematous rash, which you can see there. And a lot of the medical staff and nursing staff were concerned about how rapidly this rash appeared and was spreading. We didn't initially know what it was. 2 days later, as you can see, the rash turned blistering, and it was incredibly painful and sensitive for him. And he was diagnosed as having a cutaneous vasculitis. This then developed, and by the 11th of February, the blistering had stopped, but it had left behind this deep necrotic damage. The pneumonia was resolved, however, the renal failure persisted and he was transferred to another hospital for ongoing renal input and dialysis. So I lost touch with him at this point from the acute. I then picked him back up in my community role on the 12th of March, and this is what we had. When we look at our Times wound bed assessment here, we had 60% slough, we had 10% necrotic tissue, and we had 30% granulation. There were no signs of infection, but obviously there was a high concern that this could become infected. You can see there our measurements were 21.5 by 6 centimetres. What was the treatment plan? So the aim here, because of the size of the wound and where it was and the fact that it was really impacting his life, he was off work, he didn't feel he could go out of the house, and we really wanted speed. And what we wanted was to remove the devitalized tissue, remove that necrosis, and allow application of negative pressure wound therapy. In our case, it was the VAC therapy. And in order to apply that, you want 25% slough or less on your wound bed. So what we did was we applied Flaminol Hydro with an adhesive silicone foam on the top, and that was changed every 3 days. We chose Flaminol because it removes debris, it promotes moist wound healing environment, it protects against infection, and it's really conformable and easy to use. It worked really effectively, and within 10 days on the 22nd of March, although the size of the wound was pretty much the same, we had a lot less slough and we were able to commence negative pressure wound therapy. That went for 8 weeks. And this is how it looked afterward. The Times wound bed assessment now, we have only 10% slough, 70% granulation and 20% epithelialization. There was no signs of infection. There was still minimal exudate, but there was more exudate than there had been pre-starting VAC therapy. Our aims now are to promote moist wound healing and encourage the continued healing of this wound, which, although smaller, was still sizable and it was still impacting his life. What we really wanted to do was we wanted to get to a stage where he had less trips because he was going every 3 days to the treatment room. We wanted less trips to the treatment room. We wanted him to get back to his job. We wanted him to be involved in self-care. He felt like he had a really positive experience with Flaminol from the first time with its rapid removal of the necrotic tissue. And when we suggested trying Flaminol Forte, the same name, the same tube, but a different color, he was really happy to get on board with that. And he was able to reach the wound himself and apply that. We got him Dopplered, fitted up and measured for compression hosiery. And we got to a situation where he was able to change the dressing himself. And he was only going in to see the treatment room nurse once a week so that she could kind of have oversight, double check he was doing fine and redress that for him. So that continued. He was every 3 days. He had Flaminol Forte, adhesive silicone foam, and his compression hosiery. And this was him by the 31st of August, 5 centimetres by 2.5 centimetres. We were all really, really pleased with that. And if you have a look back, that's how far we came. He was back to working and he's minimal dressings, minimum impact to his life. And he said himself, he really didn't expect it to heal. So we were all, really, really pleased with the progress that we made with what were 2 pretty simple wound plans, really. So what was the outcome for him? Back to work, self-caring, in the treatment room once a week. His hosiery was reviewed every 6 months, but as we know, leg ulcers are very common at reoccurring, and this is a lifelong commitment to compression hosiery, to compression garments, and to making sure that the wound doesn't break down again in the future. The study by Guest 2020, which well-known study, showed that on average, patients can receive up to 8 different dressing types in a 1-year period. This isn't necessary. Flaminol's really versatile, and in this situation, we were able to change from the hydro preparation to the Forte preparation, but fundamentally, Flaminol gel, silicone foam, and compression. And the patient felt happy with that. He felt like he trusted Flaminol and he believed in it from the first time he had it. And also he felt it was easy enough to apply and he felt secure using it. We don't need to keep changing dressings when you've got big complex wounds. One dressing that's versatile will follow you right through your wound care journey for weeks and months. So the positive patient's experience that he had initially influenced dressing selection, but also the fact that we don't need to be overcomplicating our wound care plans. We don't need to be making sandwiches. We don't need to be changing things for the sake of changing things. If it's not broke, don't fix it. And that's definitely what we found in this case study. Thank you so much for listening, and thank you for joining us on this webinar.